another workshop. It is a workshop about the treatment of the defect of the femur. We did the tibia defect, and now with similar frame, we should do treatment of defect of the femur. You see this big defect here. It's practically 10 centimeters, quite 9 centimeters of defect. Not easy case, and we should do it. Good job. Well, like I explained you, to the tibia, it's difficult to say that in each case is standard to treatment. There is different cases, different approach of treatment, and when we do defect of the femur, we try it in the beginning to put to start the put frame in the way when I do surgery of resection or resection cleaning of the osteomyelitis or bone defect or pseudarthrosis. I have a frame, initial part of the frame, build it on the femur. In the way I may manipulate the bone better than if everything will be free. For this reason, what we do, we start of applying the proximal system to the femur, and after that we do job to the distal part of the femur. What we do now, okay, I have prepared this system. And I start job with the half pin. I put the half pin on the mid shaft on the diaphysis of the femur. Okay. What I do, I look at an fluoroscopy, like explained before, and we should put this half pin perpendicular to the diaphysis of the femur, and this way you may be oriented of the position of this fragment. Okay. And this is half pin, we fix it like this. After that, it's not easy to understand how to position this because we need to calculate soft tissue, swelling, and how the patient stay. But I think we start doing like this. We put this half pin here. We attach it to the ring. And it's maybe medium with the nut. Medium with the nut. Got a thin ring. Okay, keep this. Okay, we position this. 1 second. This is quite lateral on this. Okay. We put this half pin oriented to the X-ray. And now we fix it. Obviously, the anterior part it's a little bit near of the skin, and posterior, big volume of the muscle. Posteriorly, we should leave more space posteriorly. Okay, this way. Okay. And this way we position this half pin perpendicular to the diaphysis of the femur. Now we want to build this system of proximal system, because after that we should do osteotomy of the femur, this mid shaft of the diaphysis, for doing transport, for lengthening of the femur. And what I do, I always thinking about the deviation, probable deviation that may be done during lengthening. And what I do, because I know, and unfortunately for us, that during lengthening of the femur, we frequently have a deviation in varus, the proximal femur when we do lengthening, and going in the varus because adductor muscles are much more powerful and they create deviation in varus. To prevent this, we put this system with the hinges. In this case, we should build the biplanar hinges because I want to do the first thing, control the varus deformity. Another thing, control the procurvatum deformity during lengthening. What I do, I put these hinges a little bit higher because it should be done at the level of osteotomy. One. Another one I put posteriorly. Two holes, male.
Two holes.
Yes, I put, yes. Now this is a second. Okay, they should look one to another. Okay, like this. After that, I know that my proximal ring, we have much more muscle here. This ring should be displaced just a little bit lateral. And I create this a little bit displacement by playing the hinges. What I do, I put another male like this. Okay. After that, I change this position later. What I do, I put this. I respect the same holes. This is 3 holes here. I put in the same hole here. I touch like this. I put it near because we need to do lengthening. We may do like this, but maybe it's not so comfortable for the patient. And posteriorly, I do it differently. Okay. I do another one here, posterior, bolt and nut here. Better 1 second, may do it differently. Yeah, downstairs. Allora. Because we can't put the rod more posterior because it will be so bulky and uncomfortable for the patient. And what I do here, I do post proximal. And I put the rod here, in the same hole. And I connect them with the male. Like this. And this way we displace it, proximal ring, more lateral. And we create biplanar hinges for correction of deformity that should be during lengthening. Okay, like this. Always overlapping these hinges because they should move simultaneously in the same plane. Okay, you see this hinge we create, and later maybe do another one. No. I do it just a little bit inclination, maybe done parallel, but I know that it will be a varus deformity when we do lengthening. For correction of this, we may do more, maybe at the end we do compression from this side. I put it like this. Now, okay, now we put again the other half pin. Okay, this. We need to have a big space here between the osteotomy and the proximal half pin because the soft tissue is not so big for lengthening because defect is so big defect, 9 centimeters here. Okay. Do this. And this way you may realign better perpendicular again to the axis, and you should see in the lateral view that the ring is perpendicular to the axis of the femur. Just in the beginning you realign it and you see it in fluoroscopy. Okay, it's a little bit heavy. After that, we like explain you this fragment, proximal fragment, should be really stable during lengthening. And what we may do here, we like I explained before, we may use some kind of arch. We don't have this arch now. We have this system for inclination, or we may put la placca curva. Come si chiama? Placca curva. Or in any case, there is a space of your fantasy for connection. for example, I may do like this here. I take a post. Okay, another one. There. Big fantasy here. Now I want to create something for touching the cube here. But easy. We do with the roads, it's better. Okay. Another road, same length, 100. This. And I put the plate here, and the way I extended my half ring, because it's proximal part, like I said before, I don't put the half wire, because in the Kurgan, traditionally they use only wire, and I use only wire, but now we use half pin in the proximal femur. And what I do like this. Okay, it's parallel like this. Not again. I create this extension. Okay, now we put the cube, because better to stabilize it. And then I should arrive quite in a trochanteric area, because the proximal part larger and more, it will be more stable. Thank you. Okay. And go here. Here we use a safe drill in half pin and looking in fluoroscopy. Like this. Okay. Like this. Right angle, do you have? Right angle. So give me, please. It's easy, a little bit easy. Okay, you see it's much more stable now. This system is comfortable for the patient because the gluteus muscles will be free. He may sit. If not, the SRs will be too high. Okay, now we stabilize it. What we should do again? Now we build another system for more stability. I put another rod here anteriorly, whereas I have much more space here. I put it like a posterior post here. Okay, I put my rod. Okay, another male, connect them. That is again the biplanar hinges and the system for lengthening. This. Operation table a little bit too low. It's create me the low back pain. Yes. I need a little bit table a little bit higher. Okay. And what I do for this, I take this chair and I put sitting. In this way I works much comfortable. Okay. Okay. Now I put this third rod and later we put fourth because like I said, for better stability we always have a four rods for connection. Now we stabilize it. Obviously we should continue it because there is not enough stability now. I put usually 3 or 4 half pin on the proximal part. Maybe for doing example, we put this oblique support like this because this create 3-dimensional fixation. Maybe the 5 millimeters, yeah. 5 millimeters.
Okay. Okay.
Okay. We use this. I hope you see it. Yeah. Loose a little bit more. Yes, the half pin goes from posterior because we should repeat anterocurvatum of the neck like this. It's okay. Here we may do inclination how you want to create more stability. Like this. Okay. I fixed here. Solo piccola. Un bullone corto ce l'abbiamo?
Un bullone più corto.
Corto ce l'ho perché se no non mi entra.
Sì, cerchiamo.
C'era qualche... questo qua abbastanza corto. Aspetta. Molto bene. Okay. We should add that. Small one. Okay, this way we fixed half pin better. Okay. This is inclination. It's not easy maybe to introduce this half pin, but it's create more stability because it's like a triangular stabilization, you know, like a aircraft. It is. Fix it in this way. Oops. Yeah, this system have a special nut that it auto block it. We fix it, it's not never move. Okay, fix it here, and we fix it here. And now it's much more stable again. Okay, the proximal system now really stable. Okay, later we add maybe another half pin here, but for now we don't do this. We may do it later, or we have this, and maybe another one we have, or some.
Yep.
Yeah, because I need to put another one here. One or two. Okay, because I need to fix another with a cube, yes. Cube, maybe one whole cube. You put this. Just give me this. One whole cube. And because it will be intermedial fragment, that is this. Should be fixed at minimum with 2 half pin. Okay. I put this. Okay, when you do put this half pin, you should create the reserve of the skin between this half pin and this half pin. Tension the skin, and the way when you do lengthening, you have a reserve of the skin. It's never enough, but try to do this always. Put this tension of the skin before putting the half pin. Okay. Bolt. Not good. Well, let's use it, maybe just touch it. Okay. This is better. Okay, we fixed it. Okay, we fixed it better. Now I change this because I don't like this system. Why I don't like it? Because this rod is too much anterior. For the patient, will be uncomfortable. We do it the same way, all of this system. Like this. And I put it down, and this way it's function good. Same system. should keep it, realign it. Perfect. Always like this. Adapt like a lens. Always control the position, because the hinges should be all of them in the same plane, because if you do correction of varus, they should work in the same plane, because if they incline it, they will be blocked and then no correction achieved. Okay, now much comfortable for the patient. Okay, and what we finished practically the proximal part. After that, this rod I put it here only for orientation, but like you imagine now, with this frame, I do the resection of the bone. I did do cleaning and everything. Here I put a little bit long rod, maybe if it give me the problem to do surgery, I remove it. After that I rebuild it. And I do approach, lateral approach, I do resection, cleaning of the infected bone, and I achieve this big defect. This defect we have in the femur, we have only one bone, if you know. And in this situation, we may do shortening, acute shortening. The femur, you may do it more. But you should pay attention about the sciatic nerve, because if you do it too much shortening, or you do too much shortening for the arteries, they do like this, and there is a risk of thrombosis, or thrombosis, vein thrombosis, or some kind of lesion of artery. For this reason, I think you may do shortening, but no more than 6-7 centimeters. It is just dangerous to do 7 centimeters, I think. But in any case, you do shorten it because it's more comfortable for you for realignment. And the frame became more stable. Because what you do a little bit shortening. If a defect is small, 4 or 5 centimeters, you do acute shortening, it just docking site working from the first day of the surgery. If you can't do too much shortening, you do partial shortening, and you recover lengthening in the future. What we do now, we have a plate here, we maintain the distance, we don't remove it, we mount in our ring here. This 80?
180.
Yes, 180. Big one, maybe this. Okay. In this case, we use the same ring. Maybe in your operation room, you have a different size of the rings. Probably this intermedial, the 5 or 8, it should be a little bit bigger. This patient, this bone, don't have muscles. We don't know how it is, but the real patient have a big amount of muscles, and here you should put a little bit bigger in. In distal, maybe it will be a little bit shorter. Okay. Okay, we do the cleaning, we close the wood, and we position the ring. What we do, we orient it again on the line of the condyle, like explained before. If you sure that you achieve a good realignment, you may put straight rod like I do now, because I don't have deformity. But if you okay, now we do like this. If you are not sure about the correction, you may build the same system distally with the hinges, because this defect here, because what may happen, you do correction, you do compression, but sometimes it goes in varus and valgus, and you may do these hinges. But maybe easier in this case, because the defect is bigger one, we do slowly we do compression, When we arrive in contact, you may change the rods, you put the shorter rods, and they build these biplanar or monoplanar hinges to correct deformity of the distal femur. We may do correction of varus, valgus, translation, and in this way you achieve a good control of the docking site. Or another way, you arrive to the docking site. If you want to do another surgery, clean it, you may do another surgery, put it in compression immediately and solve the problem. Okay, we do another road, 200, yes. I put here. They should be parallel. Just a little bit, attach it, the system here. I put this. Okay. Now we have a space, more space. Not parallel. It's not parallel. Because I put it differently. Okay. You should stay parallel always, you know, you see the respect to the row, to the holes. I put this in internal, and I should put internal here. And the same way here. If I put it as external line for their holes, I should maintain external line. Okay. Okay, you should center your ring on the distal part of the femur, because if it is displaced or maybe not realigned good, you should adjust it with an oblique rod or some plate, because we have a different plate and we may adjust it. So, like I said before, this ring may be a little bit smaller. If you have smaller ring, you add a different plate, short, long, or something like this, in the way you connect proximal and distal ring with this plate, adjuster plate. And you compensate diameter of one ring and another ring. Now we have the same size, we don't need the plate, but that's only for understanding. I show you this. I put now another rod. Here. Okay. Okay, now we have a 3 rod. Later we put another one posterior, but for now it's not possible for our system of fixation. Okay. Practically, we did this temporarily, and now we should fix distal femur. How we do this? We start with maybe with the wire. Okay. Put any wire, smooth wire maybe. And like I said you before, when we put in the wire on the distal femur, we always should control the knee flexion. Yeah, because the displacement of soft tissue is completely different when the knee flexed and when the knee extended. This first wire, when you put it in this position perpendicular of the distal femur, if it is going in exactly in this frontal plane, there is a less displacement of the soft tissue and there is less impingement of the knee motion during the treatment. In any case, what you put the wire maybe like this, and you control the knee motion. If you see that the knee motion is not good, what you may do? You may do like this. You put again the drill, okay? All the skin tension here. You may flex the knee, flex the knee of the patient, and after that, introduce the wire again. If it is not good from the lateral side, what you may do? You may cut the wire here and do this cut obliquely and do the same job here. You cut the wire oblique, attach here, control the knee like this, goes like this, the wire. You flex the knee, skin displacement, and you reintroduce the wire again like this. And this way you achieve good movement of the knee. Obviously, if this fragment is not stable, it's difficult to do this job, you try to do how it's possible. Okay. Now we attach the wire. Maybe you could, obviously better to control the position of this wire in fluoroscopy because you see the level of the wire, you see where the bone is good, and you see realignment, like I explained you before, that this joint line is inclined at 7 degrees of the, respectively, of the anatomical axis of the femur. Okay, fix it. Good. Now we fix this. Tension the wire. System. Okay, with tension in classic way. In this way there is no displacement, nothing. Okay. Because this wire source should be centered good, realign it good. Okay. Here we do the classic way, cut, bend. Okay, and after that we should improve stability with the half pin. Okay, we use this and this, maybe lateral. Now we use a 2-hole post. here to cube. This half pin lateral should be done from posterior. Another small bolts maybe you have. Okay, okay, half pin. One here. And the same principle here. When you put the half pin, there is you go through the fascia, posterior part of the fascia. And what you do, when you put the half pin, fix it with a small bolt or medium bolt. Just more stable, the system. Each time you introduce one wire or one half pin, control the flexion of the knee. Because in this way now, you flex the knee. If the patient have difficulties, it's better to cut around this half pin a little bit, to cut the fascia, and the way the patient move the knee. Okay? After that, we move to the medial part. Here we use a small bolt again, and this half pin small. Oh, maybe it's okay here.
Yeah.
Oh, here is okay. Okay. Now we put this half pin. They will be crossed one with another, like this, from posterior part. Okay, controlling fluoroscopy, it should be not so long. Okay. And the same principle, when you put this half pin, flex the knee, do a little bit of cutting of the skin and the muscle under the skin in the way that your knee will be flexed. Just in the beginning, you should achieve good flexion. If we want it possible to put another wire in the distal part, but not so much crossing, because one wire it's maybe not enough in this case, because the frame should stay for a long time, and we should maintain for long. Okay, take this. I don't do too much crossing, just a little bit. Put here from below. Okay. Look it for 3 holes. Oops. Okay. We may put like this. Okay, I distance it again from the rod, and we will fix the wire with this male post, like this or like this. Yeah, we have. I saw it was one with a hole. We don't have hole. Yes, with the hole, because it goes in center, I use the bolt with the hole. Thank you. The same, like I said before, you might do tension with a post, but we don't do it always. We do better here with a tensioner. Now we position it another post here.
So always with the hole.
No, we don't need here the hole. We look for the free falls here. Much comfortable here, and I put washer. Maybe we have one washer. Okay, like I said, you never bend the wire, because if you see this wire don't touch the post, you need to put the spacer, washer, and the way when you touch the bolt, it's maintain original position. Okay, go inside of this. Okay, try this. Try this. Okay, do classical way, cut, bend. Okay, and now here we may do the tension. For achieve tension with the tensioner here, not so comfortable, we may use, this is posed side here. Keep the cube like this. Okay. The tension of this wire should be not so big, because if the post don't resist so big tension. It will be, like I said before, maybe 80 kilos, not so much. But we put this wire oppositely, because in this way they fix it better the distal part of the femur. More distributed this wire in half pin, better stability for the fragment. Obviously, patient in this clinical situation, patient have a just rigidity of the knee, because if there is infection, there is a defect, the patient don't move the knee really good. For this reason, important to achieve much possible movement during surgery. Okay, now our frame is ready. Practically we prepare everything for doing bone transport. We need again one rod lateral. Here we need to put it. Now I don't have too much space here because of this system of fixation, but I put it near in the way you understand. But it's better to put it in medial side, connect it with the plate. Okay, and another system we should put here. Theoretically we should put force, another system here. Do we have two posts? Okay, like this maybe. Male. Because I need to keep another system here. A small bolt, please. Small. Okay. This rod not good here. You need another rod with female, like this. Maybe you put
Two
more.
holes.
One hole with female nut. Okay, fix it, please. Okay. Because this important system, because we need control the varus during lengthening on the proximal part. Okay. Nut. When you build by planar hinges, always do this system of attachment. First, they put the post, like a two-hole post, for example, the first step. The second step, to put this rod with the female. And the third step, put the male again to connect them between them here. Okay. One nut. Okay, this system much more stable. 4 rods connect them, and this way I show you how we make control the lengthening and correct the deformity during lengthening if it's created. Because it's not only the bones, we should always thinking about muscles and about the tension of the muscles and the fragment displacement. Because if you put all straight, it looks nice frame, but it's not functional. What we do now we remove the plate, yes, and we will be in the real life with a defect of the femur.
Mi sa che è spanata.
Un po' così obliquo. Aspetta. Probabilmente we should tension something. So under, okay. Bene. Remove this. Okay. And now we remove another 2 screws in this way, and defect we have. Okay, this is cortex screw. This is metaphyseal screw. Okay. Plate is attached, disattached. Okay. Nice. Now we have a defect. We should connect later. Maybe we connect with this rod, but it should be posterior one. And we proceed with the surgery. We need to do osteotomy. Like I said before, we should disconnect them. Now maybe we don't do it because it's the same procedure. But you need only to release a little bit nut. Like I said, we sign the length of this rod with a marker. In the way when we finish osteotomy, we put all stuff in the original position. This is important things because after osteotomy, there is really dangerous to have displacement. There is no displacement, better is. Okay, I do osteotomy here. If you agree with me, from medial side like this, okay? Not so easy. Okay, I do osteotomy. It's not important, it may be transverse, it will be a little bit oblique. Important thing to do osteotomy. Yes, I use, like I said before, always osteotome. I don't do pre-drilling, I don't use the drill for doing holes on the bone. I prefer to do it only acute osteotomy with osteotome. Okay, like you see now, we are practically ready to do the bone transport. Like we explained before, what I do shorten it here. Slowly, you may do it distally or proximally where you're more comfortable. We short here. We do progressive shortening. I may do it here. And this way, defect became smaller and smaller. Here, like this. We continued to do this slowly. Obviously, when you arrive in contact, we should control it if there is displacement or not, and you may do it in operation room if you prefer to do revision of the docking side, or you may do translational system and realign it with this system. In the proximal part, what we do, we do lengthening. Lengthening of these 4 rods simultaneously, slowly, 1 millimeter a day. And we achieve this lengthening like this. Okay. And this system now, like you see, it looks nice because we don't have a muscle tension. You see, the lengthening procedure is easy, really straight bone, no displacement, no any movement. What in real life what's happened? Because when we do lengthening, what's happened? The proximal fragment goes in varus. There is always tendency to go in varus. And if we look to the X-ray, it will be plus minus like this. The femur, if you see it, yeah, the proximal femur, and a little bit in varus. The more you do lengthening, more it goes in varus here. Okay? Because the wires is bended, tension of the muscles too big, and we don't have a fixation like a wire fixation inside of the bone. It is, how to say it, it is only attaching from one side and another side is bended and femur goes in varus. And what we do lengthening. When we finish lengthening, what we do practically, we stay firmly with this rod, medial rod, these hinges works, and we may do, or again, doing a little bit more distraction of this rod for correction, but it's better again to achieve as much as possible lengthening, and when regenerated start forming, there is no shortening. What you do only compression of two external rods, this way. And this helps us to correct varus deformity, like this, you see? We could do compression of external rod, and we do correction of varus, and we correct varus in this way. But only after you achieve the lengthening, because if you do it before, you go in shortening, you don't have any correction. In the same system, this was, you may use it for correction of procurvatum or recurvatum, because when we do lengthening, another complication may create, this is a procurvatum deformity. I show you how it may be, practically like this. All these hinges should be free. Yes, and like you see now, there is a procurvatum, no? And this is, if you look at the lateral view, it looks a procurvatum deformity. And what we do for correction of this, we compress lateral rod here. Then we distract the posterior rod. Like this. All the corrections should be done slowly or maybe quite acutely, because if the generated is elastic, plastic, like a rubber, you may achieve it quite immediately. Or if you prefer, you may do it in a few days. And this way you control the correction of procurvatum. Okay, only with your hand. We continue lengthening proximally, compression distally, and you achieve the healing of the bone. If the defect is so big, maybe you don't need to do complete restoring of defect. You may leave the shortening of the leg. In the future, you may do another lengthening. But if it's possible, better to do it one time, all this treatment. Okay, thank you. We finish this workshop. Your question about this?